Thank you very much. Hello, everyone. I'm Vince Palusci. I'm a pediatrician in New York City, not St. Louis, but I work at Bellevue Hospital, and my co-presenters here today are Terry Covington and Patty Schnizter, who worked at the National Center for Child Death Review and Prevention. I wanted to talk about defining and identifying near-fatal child abuse, because child death reviews currently mostly look at dead kids. How do we figure out the kids who almost would have died? So let's look at what these near-fatal injuries may look like. Let's summarize a little bit about what the U.S. defines them as, and maybe how other people have taken those definitions, and maybe propose new definitions that are a little bit more workable. In the background, we have lots of kids dying from child abuse. We know about 1/3 of them, but that's thousands of kids. And we know that the kids who almost die are a multiple of that, at least 2 times, perhaps more. And so CAPTA and the U.S. Commission to eliminate child abuse fatalities has said, let's look at near fatalities. But how do we find these kids? We go back to our bioecological model, where you look at predisposing factors, look at the type of maltreatment. Is it abuse, neglect? We know neglect is associated with lots of maltreatment deaths, probably more than physical abuse. Do they make it into the hospital? And if they do, what kind of injuries do they have? And perhaps what happens after? Do they make it out? Or they get discharged or transferred? But start to then ponder this, and you realize that for every kid who dies that you know about, there are at least 25 kids in the hospital, another 900 or so that are treated in ERs, and many more than that never make it into a hospital setting. And all of this is costing money. And how do we as child death review people find these kids? If we do find them, we could meet more regularly. We could talk about things, hopefully, that prevent these fatalities. We can act in real time to help their siblings, and we can also do some quality improvement for the agencies that we work with, be they medical, child welfare, or law enforcement. And it really gives us a chance to act before the kid dies. Now, what the U.S. says we're supposed to review are kids that have an injury or something happening to them that a physician says was near fatal, or perhaps a serious bodily injury, which it's a substantial risk of death, extreme physical pain, or disfigurement. But other states have taken that and run with it to come up with new definitions. So some states talk about a critical condition, egregious injury in one state, just a serious injury to any kid who's in foster care in another state, or a hospitalization that requires pediatric intensive care. So there are lots of ways the states have tried to work on this, and we know that just being in CPS increases your risk of fatality with the same injury pattern. And that's kind of scary. Same injuries, being known to CPS means you're more likely to die. And so among these open cases, you can look for parental factors, you can look for mental health, substance abuse, we've heard about some of that today, but it really comes down to how are you going to define this? Is it every kid who comes into the system with an injury? Are you going to be just near fatal or serious injury? How are you going to deal with the numbers? They may be multiple numbers of the kids you're currently reviewing. And where are you going to do these reviews? These are kids who are still alive, still in the medical system, and who have privacy concerns, HIPAA and otherwise, that may prevent these reviews. So we looked a little bit with this research on the factors that may differentiate a fatal versus a non-fatal outcome, and how do you diagnose that in the hospital setting, or the ER setting, or the outpatient setting? And maybe it's different for someone in each of those settings. So you might have to look at different places to identify who's going to die. One study looked at this very question and came up with a whole bunch of factors, mostly linking this to psychosocial risk factors. So we're left with psychosocial risk factors that are present in lots of kids who die and who don't die from near-fatal child abuse. And we find violent criminal histories, prior child or household social service involvement, domestic violence. A big one is how the parent views the child and their negative attributions towards child development, and in some senses leading to harsh physical discipline and harsh parenting. And of course then the mental health and the substance abuse issues that we've talked about today. We looked at the kid inpatient hospital database for 1 year with a national survey of hospital admissions to look at young kids with certain ICD-9 codes to try to figure out which kids died or didn't die in the hospital with child abuse and neglect. And we compared those cases using basic statistics and found out really that once the kids are in the hospital, it's actually harder to figure out who's going to die because the biologic factors are taking primacy. Regional factors come in, type of injury, number of diagnoses, chronic conditions, but not the age, gender, race, and income, and some of the other factors we've heard about. So how do we find these cases outside of the hospital? Well, you can start with all CPS cases. You can look at hospital emergency department records or inpatient records, look at EMS run sheets. Teams have a variety of places to look, and it's not quite sorted out what the best way will be to identify who's going to die. And so you'll have to think about your states as laboratories. 10 states are currently looking at these at the state level, just basically pulling state databases in to try to figure out who might have died. 7 states are doing internal reviews in their Child Protective Services Department. Another 6 states are looking at local teams who have access to local ER data. And so the experiments are going on. I wish we had the science to answer the question, but we still have to deal with HIPAA and the privacy concerns. This prevents us from going into medical records as a child death review team, even though we have lots of protections. And it turns around that we're trying to work around HIPAA in several ways, using state authority, using public health law to get this information. But we do need a consistent definition to start. I think if you want to look at near fatal deaths, you should look at illness severity, significant injury, whether the child needs critical care, what is the suspicion or report of abuse and neglect? Is it just a physician saying this kid might have died, or is there some real meat to that decision that gives you some predictive nature? So these questions come to, are there significant differences between children who die, or those who don't, who have quote-unquote near-fatal injuries? Are there better medical diagnosis codes predictive of this? How do we best select these cases and integrate them into a standard fatality review process and use this to target families to improve children and families? Thank you very much.